Thanks, Natasha. Hi, everybody. I'm Elizabeth McNamara. I'm a physician at Barton. I've been an emergency physician for the last 12 years, and from the very beginning of my experience as an emergency physician, I was very interested in patients with addictions and substance use disorders. And now that's what I do. I split my time between the emergency department and the outpatient clinic where I practice addiction medicine, and it's really become my passion. So I'm really happy to share that with you. Um, for the past 4 years, I've been involved with the Substance Use Navigator program at Barton, and I've been the clinical champion for that program, which has been supported by grant funding from the state of California. We've also had amazing support from our institution, and we're growing that program. And my current work is centered largely around starting an addiction medicine service line. And what that means is that we're looking to provide dedicated addiction medicine care to people who need it outside of and in addition to their routine healthcare. So we're looking to launch that within the next month to expand access to care for people, and I'm really excited to see where that goes. So my talk tonight is called Understanding Co-occurring Disorders, the complex relationship between mental health and substance use disorders. And thanks for being here. And hi, Mom. Um, okay, so just a little clarity here. So I'm going to focus on mostly anxiety and depression because those are the most common mental health problems that we see. And also those are what are called mood disorders. And for substance use, my most of my experience is around alcohol, opioid, and nicotine and tobacco use, and to some extent cannabis use. So I'm largely going to focus that. I have a lot of patients with co-occurring methamphetamine use disorders, so that is applicable to this. And I also want to say I'm not a psychiatrist, I'm not a psychologist. I recognize that that means I do have some limitations. So I'm going to bring who I am now to this conversation. Given what I do, I certainly lean more towards discussing substance use than mental illness, and you'll see that in this talk. Please feel free to ask questions in the chat if you need any clarity or if you have any additional information that you require, and we'll have time to talk at the end. I want to start with two quotes that I really, really like. The first says, if you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And this man, Don, was a person who worked in recovery with people. I think about this a lot, especially when we talk about stigma and shame around substance use and mental illness and people seeking care. The second is from an article I just read within the last week. It's by a gentleman named Roger Roseblatt, who wrote a book about aging. And this article was called 10 Tips for Being Healthy, or Being Happily 85 Years Old Like Me. And he says, everyone's in pain. If you didn't know that before, you'll know it now. People you meet casually, those you've known all your life, the ones you'll never see, everyone's in pain. If you need an excuse for being kind, start with that. And that aligns with actually the first noble truth in Buddhism, which is that suffering is an inherent part of life. I don't practice Buddhism, but I really appreciate that that's a way to approach the world. So, a few goals. We're going to talk about some definitions. I will talk about mental illness and substance use and their relationship. I'm going to go through the roles of trauma and stigma in the development and also in barriers to treatment. I will talk about treatment, recovery, and then talk about getting help for substance use and mental illness. I use person first language. What that means is person first or people first language focuses on the whole person, not their substance use or their mental illness. This puts the person's worth before their condition or circumstances. So I'm going to just go through these things in the way that I say them. She uses drugs. She is struggling. It sounds like you may have depression. I am worried his alcohol use is harmful or hazardous. He has a substance use disorder. I have been abstinent from alcohol. They are in recovery. You have a positive urine drug screen. She is a person with mental illness. The baby was born with neonatal abstinence syndrome. And I'm sure you can imagine the alternative things that you could say. And hopefully by the end of this talk, you'll have a good understanding of why this is my preferred language. I do recognize that some people in recovery, particularly people in recovery from alcohol use or people involved in 12-step programs, may call themselves alcoholics or addicts with pride. That is their choice. I respect that. And that is not the language that I use when approaching patients. So first to talk about the impact of mental illness. This is information from Mental Health National. It says you are not alone. 1 in 5 US adults experience mental illness every year. 1 in 20 US adults experiences serious mental illness, and almost 20% of youth experience problems with mental health. Most commonly, those are anxiety disorders, then depression. Per Mental Health America, lifetime prevalence of mental illness is 46%. So about half of people in the United States experience some mental illness in their life, and half of that occur by age 14. So, about 1 in 4 people experience onset of mental illness in adolescence or earlier. More than 50% of adults with mental illness do not receive any treatment, which is multifactorial and related to stigma and shame, and also to availability of mental health providers in our country. An even lower proportion of people with substance use disorders seek treatment also for very similar reasons. And this is to acknowledge we are all in recovery. 2020 was not that long ago. It was a very, very challenging year for people. There was so much loss, so much uncertainty, so many challenges for people. I'm going to kind of go left to right on this infographic. 1 in 5 American adults experience a mental illness, which, as you saw in the prior slide, is similar to the usual prevalence. 1 in 20 experience a serious mental illness. 1 in 15, so about 7% is the estimate on this, experience both a substance use disorder and mental illness. And more than 12 million people had serious thoughts of suicide. 1 in 5 people, which seems a little low to me, to be honest, report that the pandemic had a significant negative impact on their mental health. And those were people with mental illness and with serious mental illness. And among US adults who receive mental health services, there were significant delays and cancellations in appointments, delays in getting prescriptions, people who could not access care, people using only telehealth as an option, and a lot of people receiving virtual mental health services. I think we're still seeing a lot of reverberation from what happened during the pandemic. And also, it's not a coincidence seeing these numbers that the pandemic was a time of a significant increase in overdose deaths, which is probably starting to level off, but that did take some time. So a little bit more about mental illness. Doctors love numbers and screening and tests. So here are some tests that you may see at your doctor's office or at an appointment or with a therapist that try to quantify anxiety on the left side, depression on the right. The left side is what's called the GAD-7 score. It has 7 different criteria that when you add them up, they help to quantify, do you have no anxiety, moderate, mild, moderate, or severe anxiety? So those are things like feeling nervous, anxious, or on edge, having trouble relaxing, being annoyed or irritable. On the right side is what's called a PHQ-9 test, which is sometimes administered as a PHQ-2 test. That is for depression. Over the last 2 weeks, how often have you been bothered by these symptoms? Little interest or pleasure in doing things, poor appetite or overeating, all the way down to 9, which is thoughts that you would be better off dead or of hurting yourself in some way. Obviously, people can have symptoms of anxiety or depression that don't fall into these categories, but these are screening tools I use a lot in clinical practice to see where people are and see how they progress in treatment and see what the impact of different life events are on their mental health so that we can really look at it and say, well, a couple months ago it looked like this, now it looks like this, etc. Turning to the impact of substance use, and we'll come back, we're going to put all of these things together. I use the National Survey on Drug Use and Health a lot to get data around substance use and mental illness. The most recent data we have is from 2023. So this graphic shows all Americans and the people in the United States who have past year substance use disorder, which was estimated to be, just under 20%. I'm going to add a little caveat to that in a second, but you can see alcohol use disorder is by far the most common. Drug use disorder here is cannabis, cocaine, heroin, hallucinogens, inhalants, methamphetamine, and prescription medications. So that is a number of things that are categorized together, excuse me. In clinical practice, I separate those out because the treatments are different, but you can see as a chunk, those are all similar. And then marijuana use disorder or cannabis use disorder is separated there too. So I'm not totally sure of the distinction between those two, but I think it's helpful to see as much attention as we really pay to the opioid epidemic, which is appropriate because it is really impactful on our national health. Alcohol use disorder remains in the background as a significant significant substance use disorder that remains prevalent. Tobacco and nicotine use isn't included in this study, but the data from the same year reports that 22.7% of people report past month use of tobacco or nicotine products. And the estimates are that about a third of those people have a use disorder. So around 8% of people have tobacco or nicotine use disorder, which would rank it after alcohol use disorder and between sort of drug use disorder and marijuana use disorder on this chart. This just gives a shot of like what's happening in the past year, right? If we look at aggregate data from all people in the country, there's almost a 30% lifetime prevalence of alcohol use disorder. So what that means is if you take 100 adults over their entire lifetime, 30 of them will meet criteria for alcohol use disorder, which we'll talk about in a minute. And other substance use disorders, there's up to a 10% lifetime prevalence. So not only are these common within the span of a year, but they're also common over the lifespan. And we're always making new recruits. Every year, this is past year initiates of substances. So this is not people with a substance use disorder, but this is people who've started using various substances over the last year. You can see right now, nicotine vaping leads the way. Alcohol is not far behind, and marijuana, which I refer to as cannabis, is a little bit further behind that. So a steady stream of new initiates who are at risk of developing substance use disorders. This is a little bit of kind of where the rubber meets the road. So I already cited like maybe a 7% coincidence of mental health and substance use. The National Alliance on Mental Health and Mental Illness, which is NAMI, estimates about an 8% co-occurring substance use disorder and mental illness annually. I like the way that it's laid out in this picture. So the blue circles on each side are people with substance use disorders, and that is the same size on both sides. The left one is really of more interest to me because it's all adults with any mental illness. That's the yellow and green. And you can see the overlap in the green is people who had substance use disorder and any mental illness, which is what we're talking about tonight. On the right side, it does show people with serious mental illness, and the purple being overlap between serious mental illness and substance use disorder. You can see that that is actually maybe a little bit larger piece of the circle than the all mental illness people. But these are usually put together when they're reporting numbers for everybody, like population-based numbers. So what is a substance use disorder? A substance use disorder, we use 11 criteria. Like I said, we love using criteria and numbers to quantify the degree of a substance use disorder. And there's four major categories. The first category is impaired control, which is using more of a substance for longer than intended, persistent desire or unsuccessful efforts to cut down or control use, spending a lot of time obtaining, using, or recovering from the substance, and a craving or a strong desire or urge to use the substance. The second is social problems, failure to fulfill major role obligations at work, school, or home due to substance use, continued use despite persistent or recurrent social or interpersonal problems caused or worsened by use, giving up or reducing important social, occupational, or recreational activities due to substance use. The third criteria category is risky use, which is recurrent use in situations in which it is physically hazardous, continued use despite knowing that it is causing or worsening physical or psychological problems. And the fourth is the physical dependence or pharmacological criteria, which is tolerance and withdrawal. Tolerance being a need for increased amounts to achieve intoxication or the desired effect, or a diminished effect with continued use of the same amount. And withdrawal is manifested by characteristic withdrawal symptoms for the substance or use of the substance or a closely related one to relieve or avoid withdrawal symptoms. In order to qualify for a substance use disorder, only 2 to 3 of these criteria need to be met. That would be mild. 4 to 5 criteria are moderate, and 6 or more criteria are severe. I'm sure you can imagine in my practice, I see people who often fall into the severe category. And I'm also sure you can imagine that it would be fairly easy to go through a period of time in your life where you would meet mild criteria. That's represented by this. So this, there's a bunch of bars here. It's in 3 different parts. There's substance use disorder, drug use disorder, and alcohol use disorder. And you can see the bulk of each bar is taken up by the dark blue, which is a mild substance use disorder, and smaller proportions are for moderate and severe substance use disorder. There's also breakdowns by age, which can be really interesting. I'm not going to get into that further now, but that does represent it's much more common to have a mild substance use disorder than a moderate or severe substance use disorder. But which came first? I get this question a lot. So addiction is often what causes biopsychosocial impairment or brings people to healthcare. But I consider it to generally be a symptom of another underlying problem, which may or may not be obvious. The reason I say that is because the waters you swim in are the waters you swim in. You may know they are tumultuous. You're suffering with anxiety. you have depression, there's another condition, medical problem maybe that you have, or you may think that they are normal until something happens that suddenly make those waters calm, and then you see how tumultuous they are. That something in many cases is the development of a substance use disorder. Somebody starts using a substance, they notice that it makes their inner world different than what it was, and then they continue using the substance. Therefore, in an odd way, the addiction is the solution. But as we're discussing, treating the addiction without treating the whole person is not a good way to have success. As I mentioned before, lifetime prevalence of mental illness is 46%, so almost half, and half of that is by age 14. Early initiation of substance use, like alcohol, cannabis, nicotine, tobacco, and others, is particularly alarming because the prefrontal cortex, which is the part of the front part of the brain that is responsible for many functions, including executive functioning, impulse control, attention, working memory, emotional regulation, personality, social behaviors, judgment, risk assessment. It does not complete development until the early to mid 20s in women and the mid to late 20s in men. This is why adolescent behavior is what it is. And I worry that routinely using substances that deepen disinhibition and impair these important tasks in adolescence delays maturity and adult development. So when a person develops a substance use disorder before their brain reaches maturity, the chicken or egg question becomes particularly salient because it is hard to see which is which. Added to that, associations between substance use and mental illness have been widely publicized and can be scary. For example, this graph shows age-dependent association of cannabis use with risk of psychotic disorder from a study in 2024. The green line shows teens who didn't use cannabis who have a low incidence of a psychotic disorder. And the purple line shows teens who use cannabis, and you can see it rises sharply, suggesting that there is a significantly increased risk. When looking at data like this, it's really important to remember that causation is not the same thing as correlation, and that there may be other factors at play here. But it's fair to be alarmed by this, and I'm sure we'll hear more about it with time. I think the chicken or egg question is a concept to keep in mind, and it's one that I often discuss with patients to help them understand how their brains work. For this audience tonight, I have two general recommendations. The first one is delay initiation of drug use as long as possible to allow for brain development. And the second is to get help early when you have concerns about mental health, substance use, or even more broadly about development and coping skills. Now let's turn our attention to trauma. When we talk about brain development and the link between mental health and substance use, it's essential to talk about the impact of trauma, and I do not think I could satisfactorily cover trauma even if this entire lecture was devoted to it, but I would like to talk about a few basic concepts. Big T, capital T trauma is a major life-threatening event. One big T trauma in somebody's life is often enough to cause major distress and difficulty functioning. On the other hand, little t traumas, lowercase t traumas, are events that exceed our capacity to cope, and they disrupt emotional functioning while not being inherently life-threatening. These are often a part of everyday life and range from abuse and neglect to conflict with a spouse, financial stress, birth of a child, or starting a new job, so some things that are even positive. Little t traumas can be overlooked or rationalized as common, maybe because they generally impact people's lives for a short time, but compounded little t traumas can have a major impact on mental health and on coping behaviors. ACEs are a type of trauma I discuss a lot in clinical practice. The ACE study was a study from 1998, which has a lot of validity even today. It looked at 10 types of adverse childhood experiences and the risk outcomes that were associated with exposure to them. Those were in three categories that you can see here. The first was abuse, physical, emotional, or sexual abuse. The second was neglect, physical or emotional neglect. The third was household dysfunction, which includes mental illness, an incarcerated relative, a mother treated violently, substance use, or divorce. The prevalence of ACEs in this study are shown on the left side of this screen. So physical, sexual, emotional abuse are all in the first kind of category there. Neglect, emotional and physical neglect, and then household dysfunction. So you can see they have varying rates of prevalence. And the bottom pie chart here showed of 17,000 people in this study, about a third had zero ACEs, but about two-thirds had at least one ACE. And about an eighth of people, or 12.4%, had four or more ACEs. The impact of these adverse childhood experiences is that they could have risk outcomes that are shown on the bottom right here. So as more ACEs occur, risk can go up, but it's not determined. And the behaviors associated could be things like lack of physical activity, smoking, alcohol use, drug use, missed work, physical and mental health consequences, severe obesity, diabetes, depression, suicide attempts, sexually transmitted infections, heart disease, cancer, stroke, COPD, and broken bones. So you can see there's a significant overlap of the behavior and physical and mental health, right? Just like what we're talking about tonight, substance use and mental health outcomes, but there's also significant physical health outcomes that are associated. Now, this is not a screening or a diagnostic tool. Rather, it's really a data set that helps to show us how these 10 factors contribute to people's health. You'll notice that this does not include things like poverty, racism, community violence, or generational trauma. So in that, it's an imperfect tool, but I think this helps to inform people about where they are coming from and what their lives have given them. We know that addiction is 40 to 60% genetic, and the rest of whether or not somebody is going to develop a substance use disorder depends on other factors. My belief is that these factors are very important in that. Stigma is also something that I think about a lot and that we're trying to really combat in clinical practice. So stigma takes many forms and can be a source of both big T and little t trauma for people with substance use disorders and mental illness. Stigma is defined as negative attitudes, beliefs, and stereotypes. And here are three major categories of stigma from the CDC. So the first is structural stigma, which is laws, regulations, and policies that may exclude or even punish people with mental illness or substance use. There's public stigma, which is negative attitudes or beliefs from families, neighbors, friends, first responders, healthcare workers and systems, and others. And then self-stigma is also really important, right? Blame or shame that are associated with having a mental illness or having a substance use disorder. Stigma also has many, many ideas. We started this talk by talking about person first language. The opposite of that is identity first language. There's also a concept that you must not want to get better if you continue to especially struggle with addiction. A lot of people think addiction may be a moral failing or maybe somebody's fault. That is a sort of a type of stigma. And I really want to talk about the fourth one for a minute. Harm reduction and compassionate assistance enable continued use. That is an idea that is held that is stigmatizing. This is a polarizing topic, especially when you're treating people with substance use disorders. Engagement and safety are key concepts. Without having people alive and in a place where you can talk to them and assess their needs, you can't do any work to help them get better. It's not a rash that you treat with antibiotics. Some people don't get better. Some people get better and then they get worse again. Some people get worse after years of stability. Incorporating a compassionate harm reduction approach and prioritizing the safety of the people that you're dealing with, that you're working with, is an enormous part of doing this work. And it also fosters a collaborative treatment approach, which is very anti-stigma. This is what's called trauma-informed care. So because of the ubiquity of trauma and stigma in patients with mental illness and substance use, a trauma-informed approach to care is extremely important in supporting good treatment outcomes. Trauma-informed care shifts the focus from what's wrong with you to what happened to you. You'll note, I'll go over these 6 factors. You'll note that it's not just patient-centered care, but it also involves cultural factors in care delivery. So it doesn't just ask patients to show up and be different, it asks the people who are taking care of them to show up and be different. The first is safety, which means patients and staff feel physically and psychologically safe when they're receiving care or giving care. The second is trustworthiness and transparency. Decisions are made with the goal of building and maintaining trust with transparency. The third is peer support, where individuals with shared experiences are integrated into the organization and viewed as integral to service delivery. That's something that we're working on with our Substance Use Navigator program. The fourth is collaboration, which is the leveling of power differences between organizational staff and between staff and clients to support shared decision-making. This is a non-hierarchical approach where all people's ideas are valuable and everybody's involved in the care of the patient, including the patient. The fifth is empowerment, where the strengths of patients and staff are recognized, built on, and validated, which also includes a belief in resilience and the ability to heal from trauma. And the final is humility and responsiveness, which is where trauma, biases, stereotypes are recognized and addressed in the course of treatment. Because as I described, those are really foundational for a lot of people. So what does treatment look like? So there's the old way. I've been in rooms where this has been the way that treatment was, where you have somebody who's a mental health specialist and somebody who's a primary doctor or family physician who works on more, I would say, physical health classically. And they look at each other and say, that substance use is your problem. That substance use is your problem. And that doesn't really lead to a whole lot of progress. And so people get sick and they have trauma or they're in danger or they consider suicide. And then they sometimes end up in the emergency department. And then you have this emergency physician, which is what I've been doing for the last 12 years, who says, well, it's my problem now, right? Like, that's not the perfect environment to treat mental illness or substance use in either. But what I've learned along the way is that that is a really good place to put together the idea that your physical and mental health do overlap significantly. And that's what led me to this work. I think there have always been a group of physicians, therapists, and other people in this space who have thoughtfully approached the whole person. And I think that we're getting closer to a model that's really an integrated model of care. So in the new way, we have your psychiatrist, your family physician, your emergency physician, and an entire care team of people who think that they can help and they can contribute their skills. It's very helpful for patients to have a point of contact that they feel comfortable with in the clinical environment or in their healing environment, be that their doctor or their therapist or their group meetings or their friends or whomever that they feel like is their safe space to go to. And using that collaborative approach in a non-hierarchical way is very important for helping engage people in treatment. I put this slide up here because, I said before, like, it's not a rash you treat with antibiotics, which is like this smooth road, right? You see the doctor, you get treatment for your rash, and you're off. Like, it's totally fine. You're on smooth sailing. I talk to my patients a lot about this. It feels much more like the picture on the right, which is beautiful, but it's like bushwhacking through the wilderness at times. There's so many areas of your life that can be impacted by substance use and mental illness, and all of the contributing factors might still be there when you seek treatment. Although I showed you scoring systems for anxiety and depression and substance use disorders, that doesn't mean that when people enter into treatment, their scores suddenly or permanently improve. And here are some things, here are some things that people go through when they get into treatment. I just listed some. It's definitely not an exhaustive list, but starting medications, exercising, going to 12-step meetings, starting therapy, getting a job, dealing with legal trouble, changing medications, treating other medical conditions, reassessing friendships and relationships, relapsing, getting another job, facing loss, adjusting medications, family therapy, learning how to sleep, and moving to a new place. I put medications in here a few times to show that treatment can sometimes be a moving target. People change, new problems arise, and people heal. It can feel frustrating at times to move through this, especially as a person who wants to get better. And this is where education and self-advocacy can be really helpful. Being involved in your treatment decisions, considering including family members, friends, or other allies, and having clear goals can all ease this discomfort. I want to really emphasize this point too, which is that although medications are often used in treatment, using medications to treat addiction is distinct from having an addiction, and it is not replacing one addiction with another. This concept comes up a lot around using buprenorphine in the treatment of opioid use disorder, but it is a frequent question when it comes to medications also like antidepressant medications. If we go back to the criteria for substance use disorder and the 4 areas of impact, it's pretty clear how substance use impacts especially the first 3: impaired control, social problems, risky use. The 4th is maybe where things get a little stickier for some people, particularly with buprenorphine, because it does have a withdrawal syndrome associated with discontinuation, but so do antidepressants. However, I see that as quite distinct from the type of withdrawal experience with habitual substance use. Also, if you wanted to be really strict about it, Then it gives you a score of 1, and you'll remember that you need a score of at least 2 to meet criteria for a substance use disorder. When we're talking about an individual with many areas of dysfunction meeting 6 or more criteria with a severe substance use disorder, exiting the criteria by being on a medication that has some withdrawal risk is enormous progress, and I see this clinically all the time. Buprenorphine specifically is probably the most effective medication that we have to treat addiction ever in the history of mankind. So I see this as really positive movement in terms of how we can get people back to the lives they want. I also want to point out that everybody's body works differently. And if your body works better with buprenorphine or an antidepressant or another medication in it that's safe, and you're living a life that is also safe and more in line with your goals, that's an amazing thing. So what does recovery look like? Is it abstinence? Is it something else? Our professional societies, of course, have a lot to say about this. I listed a number of different societies. I'm just going to read one. I'm a member of the American Society for Addiction Medicine. Their definition is that recovery must include, number 1, the aim of improved quality of life and enhanced wellness as identified by the individual. Number 2, an individual's consistent pursuit of abstinence. Number 3, relief of an individual's symptoms, including substance craving. 4, improvement of an individual's own behavioral control. 5, enrichment of an individual's relationships, social connectedness, and interpersonal skills. And 6, improvement in an individual's emotional self-regulation. That's great. Let's see what patients actually think, what people in recovery actually think. There was a study in 2023 called What is Recovery? And it was a survey study with some flaws because survey studies are tricky. But it came up with 3 core elements and 3 prevalent elements that people in recovery say are important to them. The core elements are these: a process of growth or development, the practice of personal integrity, being honest and taking responsibility, having balanced reactions to life's ups and downs. And the prevalent elements were being able to enjoy life and handle negative feelings without substances, some abstinence or non-problematic substance use, and living a life that contributes to others or to one's betterment. Most respondents in this survey had some substance use related goals, using less, using none, which is appropriate. I think it's interesting also to reflect on the idea that abstinence was not a core element, and it's really part of the prevalent elements that people share. Again, a survey study, hard to know how to kind of extrapolate that information. But the most striking thing about this for me is that all of these elements that people in recovery strive for are essentially the same things that I want in my life. None of these are end results. None of these are final results. All of them are a process or a practice or an ideal. I think this really goes to show that we're all looking for similar things in life. People just come to them from different struggles. So let's talk about how to get help. Um, excuse me, here's a list. So talk to your doctor, talk to your health insurance provider about mental health resources, rehabilitation resources, other things that are available to you. There's some phone numbers here. These are all on the internet, but El Dorado County Behavioral Health, there's a 24-hour crisis line. The Barton Community Health Center is where I work. There's many providers there who are accustomed to treating patients with substance use disorders, and that's where our addiction medicine specialty team will be located. Barton Psychiatry and Mental Health, and then the Barton Substance Use Navigator. We currently have one. Her name is Azzy. She's on this call. She's absolutely phenomenal. If you're not sure what you need, she's the girl to ask. How to get somebody else to get help. This is a tricky one. So this could be a presentation in and of itself, okay? I don't know, I think this is 8 things, 8 thoughts I have on this. So the first is, if you have somebody in your life with a substance use disorder or who's struggling with their mental health, the first thing you can do is care for and educate yourself. That makes you better when you're approaching them with a difficult conversation. The second one is to set boundaries. You should love them, you can love them, but you are not to shield them from the consequences of their use. Those are conversations you can have with them about what you will and won't do to help them. Choose your timing, plan for multiple conversations. So these conversations should not be held in crisis. They should not be had when somebody is intoxicated. It can be helpful to ask to schedule a time to talk. hey, I'd love to have a conversation with you after dinner tonight. I really want to talk to you about something important to me. You also have to be ready to stop a conversation and plan to restart it when it gets heated, and practicing some scripts around that for the conversation and before everybody's blood pressure is really high can be helpful. Approaching with kindness, empathy, and accountability is another tip. Accountability is in there because most people who are trying to approach a loved one with a substance use problem have probably already approached them before, and it may not have gone well. I think that using accountability to show up for those conversations is really helpful. Hey, I know we talked about this before, and I was not the person I wanted to be in that conversation. I'm so sorry. I'm worried about you. Can we please talk again? That can go a long way to having people open up to talk. That's a model of using I statements, sticking to the facts, saying things like, I noticed that you're drinking more. I noticed that you were drinking and you crashed your car, right? Not being like you're a drunk or you keep using, or like things that are really much more, I would say, subjective and accusatory. Stick to the facts of what you're noticing. Try to listen more than you talk. People don't tell you when you change their mind. And people who are suffering with mental illness and substance use disorders may not have somebody safe to talk to. So you can be ready in this conversation to do a lot of listening about somebody's experience. Offering specific support can be very helpful. Suggest a doctor, a therapist, a group. Offer to attend with them. Stay in the parking lot. Go into their appointment. Sit in an AA meeting with them. See what you can do to offer to help get them to where they want to go. For some people, also couples or family therapy can be really, really helpful. It can be very daunting for somebody to step into a therapist's office and figure out what to talk about, especially if they have had trauma, if they had a difficult childhood. Going into those conversations with somebody that loves and cares about them from a standpoint of let's make our family or our relationship helpful can really be a helpful step. And my last tip is have patience and be gently persistent. Again, people aren't going to tell you when you change their mind. And these problems, as you can see, develop over the lifespan for many people. And so, patiently, persistently telling somebody you care about them and you want to help them can really go a long way. All right, we made it. So we went through some definitions. We talked about mental illness and substance use. We talked about the roles of trauma and stigma. We talked about treatment, recovery, and getting help. And I'll throw up my quotes that I like so much at the end. And we can go ahead. It looks like we have a few minutes for questions.
Wonderful. Thank you so much, Dr. McNamara. If you joined us late, I did go over how you can submit a question. There is a Q&A box that if you hover at the bottom of your Zoom screen, you can ask a question. There is an option to ask anonymously. We just want this to be a safe environment where people feel comfortable asking any questions they may have. And you can also enter it into the chat. And I see some coming in. So I'm going to start with the first one. They're asking if you could speak specifically to meth use and PTSD and how to communicate well with someone experiencing these co-occurring disorders.
Yeah, that's really hard. Methamphetamine use, as you may know, is on the rise. And it's especially tricky because there are not as effective of treatments for meth use as there are for other things. I would come back to my communication tips about how to approach somebody. The most important thing I think here being to choose your timing well. People who are binging on meth or using meth, the time when they're intoxicated is not a good time to talk, but there's also a significant calm down with a lot of emotional dysregulation. And so finding a time where they're a little bit more level to talk can be helpful. PTSD is also a huge component of mental illness when it comes to co-occurring disorders. I did talk more about specifically anxiety and depression because my area of expertise is not PTSD. PTSD oftentimes co-occurs with anxiety and depression. And so my thought is encouraging that person to talk to somebody about treatment and trying to pursue treatment that is directed towards their underlying mental illness can be very helpful for reducing meth use.
The next question is, how do you know, oops, sorry, how do you know when someone is overdosing on alcohol?
That's a good question. I mean, I guess as an emergency physician, I think of unconsciousness as overdosing on alcohol. I wonder if the question is more about like how do you know when somebody is using alcohol too much, or how do you know when they're in danger and they need treatment? I think if you're in doubt of somebody's safety, get help right away, right? Call 911, take them to the emergency department. There's providers who can do an assessment on that. If you're worried about somebody's escalating use, I would go back to these tips to talk about how much they're using, what your concerns are around it, and options for help. I did not say in my slide on treatment resources, El Dorado County Behavioral Health is the resource to talk to if you have Medi-Cal as an insurance and you're looking into rehab options. So that's a really good place to talk to people.
Oh, and the next question is, why does buprenorphine seem to be the medication of choice and so helpful for substance use disorder?
Yes, I use buprenorphine a lot in my practice. So I could give an hour lecture on that. I'll just give a few brief points on it. So, um, fentanyl, heroin, other opioids like prescription opioids, those are what we call full opioid agonists, and methadone is actually also a full opioid agonist. So it completely covers the opioid receptors and turns them completely on, which puts patients or people, I always use patients because I'm a doctor, but puts people at risk of the side effects from opioid intoxication, right? The greatest of which is respiratory depression and death, which is what we're seeing with the opioid epidemic. Buprenorphine is really this beautiful molecule that's what's called a partial agonist. The analogy I use for patients is if you're using fentanyl, you're going down the highway, you're going 100 miles an hour, or you're at zero, you're withdrawing. You're going 100 miles an hour, you're at zero. Buprenorphine kind of puts you at like a gentle 35 to 45 miles an hour. Like you can enjoy the scenery, you're getting where you're going. You're not in withdrawal, but you are not so intoxicated that you're having difficulty functioning. The other thing around that is that drug use, especially opioid use and meth use to a certain extent, is often associated with a lot of behaviors around obtaining and using drugs. By using a partial agonist medication that decreases cravings and prevents withdrawal and puts people into sort of that steady state, that can really help to return them to much more functionality in terms of things like being able to care for their children, getting jobs, going to work, stuff like that.
The next question is marijuana addiction or cannabis addiction treated the same as other substance use disorders?
Yeah, so as I said before, I use cannabis. Marijuana, I think, is less of an accurate term clinically. Uh, I would say it's definitely treated differently. The conversation I have with people who come to me with cannabis use disorder or with heavy cannabis use that they'd like to cut back, it really has a few factors in it. First, we talk about the health dangers of using cannabis because there are pretty significant cardiovascular risks associated with it. Also, some pulmonary risks, especially if people have cancer, have like COPD or asthma. There is no replacement molecule or treatment for cannabis. Like buprenorphine is so applicable for opioid use, and there are three FDA approved medications for alcohol use. There is no specific thing for cannabis. I notice that people often use cannabis because they're treating anxiety or depression or insomnia or sometimes PTSD or other mental health conditions. So when I treat patients with cannabis use, I really talk about those things with a goal of let's try to find a treatment for your underlying concerns that helps to decrease cannabis use to a place that we both feel comfortable with. Sometimes they go to recreational use, sometimes they go to no use. And for some people, they really don't want to change their use patterns at all. But that's really how I frame the conversation.
There's a question about the data that you presented. It's asking the data that you presented showing how many people use or abuse. How do you know how they collected that information?
Oh,
Did patients volunteer for the survey to give the data, or is it objective coming from a healthcare provider?
I think you're talking about the National Survey for Drug Use and Health. That is a survey, and I welcome you to take a look. There's hundreds of pages for each year about how the survey is administered. My understanding is that the survey questions do ask people those questions, like in the DSM criteria for substance use disorder, to find out if people qualify. One of the reasons I like that data set is because it is not specifically limited to people who seek healthcare to help with the substance use disorder or mental illness. You could see in the data I presented, it talks about people who are trying substances for the first time or people who report symptoms consistent with a mental illness over the course of a year. It has a number of really beautiful charts and graphs, and I turn to it really frequently, especially when I make lectures to talk about this.
This might be a bigger question than you can answer, so maybe if you want to speak locally to it, but it's asking how often do people overdose on methamphetamines?
Um, yeah, I don't think I can't really give great data. I can say that clinically, this is something that I have seen where people are in acute crisis because of methamphetamine use. Um, I would say that's limited to my clinical practice. I don't have a good idea of how frequent that is, either locally or nationally, in terms of overdose. I do know, as I said before, that methamphetamine use is sort of being considered as what's called the fourth wave of the opioid epidemic. And it's really, especially in Western states, it really is oftentimes hand in hand with fentanyl. Um, and given the contamination of the drug supply, it can be difficult to find methamphetamine without fentanyl. So people who may be only methamphetamine users can be at risk of overdose from fentanyl, which is why we really talk about harm reduction and safe practices.
Are there any prescriptions that help with drug or alcohol cravings when they're trying to stop?
Absolutely. So we talked about buprenorphine, which helps a lot with cravings and helps to have people cut down on opioid use. Buprenorphine is a medication that can be titrated. It's available in injectable or tablet form. There's also a patch form that we use for patients who have chronic pain. So that's sort of number one. There are two FDA-approved medications that help with cravings for alcohol. One is called naltrexone, which is available either orally or in a shot called Vivitrol, which I use a lot in my clinical practice. The other one is called acamprosate, which is only in pill form. It's taken 3 times daily. That also helps to decrease cravings. And those two medications work on different parts of the brain. So for patients who are particularly sick with alcohol use disorder to help decrease cravings, I sometimes use one or both of those medications. Both of them have evidence to decrease heavy drinking and help to promote abstinence. No medications are proven to have persistent abstinence, but they are tools in our toolbox that can be extremely effective. And I've seen a lot of really good effects with patients. Oh, and
Go ahead.
they're also, I tend to neglect nicotine and tobacco because there's so many other things to talk about, but there are excellent medications to help with nicotine and tobacco cravings, including varenicline, which is commonly known as Chantix. Wellbutrin or bupropion is an antidepressant that helps to decrease cravings, and I also often use and titrate nicotine replacement, and that's one of the things I really enjoy doing in clinic.
How do you approach a young adult, a child, who's in college and has a bipolar and substance use disorder?
Right here. This is hard, right? College is a time of differentiation. It's a time to really step outside the boundaries of your household where you were growing up and really do some experimentation. The nice thing is that colleges have tons of mental health resources for students. Obviously, you have to consent to receive treatment, but I would go to these tools and honestly, there are a wealth of resources about how to talk to people about their mental health, about their substance use, and some specific resources around really adolescents and young adults and how to manage with them. I would say, especially if that person, I guess if that person's in your house or not in your house, getting help and educating yourself first is really helpful to have a balanced conversation about that.
Do you have any thoughts on how we reach the vast majority of people who struggle with substance use disorder that do not or cannot access treatment?
Oh, I have so many ideas. Um, it's complicated, right? There are a lot of barriers to care. Sometimes just having or not having health insurance is a barrier to care. The perception of stigma is a barrier to care. The idea of like, well, I'll just stop drinking tomorrow. I can do this on my own can be a barrier to care. I personally think that making people aware of services and also living in a community that demands high quality services for substance use disorders and feels comfortable with normalizing getting treatment and getting evaluated, I think those are important steps. If your neighbor got treatment and is feeling better, your barrier to doing it is lower. But if you don't know anybody who's in treatment, it's much harder to pick up the phone. Part of the reasons we have substance use navigators is because they have been proven in data to increase engagement in treatment because it's a special point of contact for people who have substance use disorder. And they can talk to them about, like, hey, I need help getting my prescription. Hey, I really need an appointment. I relapsed, I'm not doing well, stuff like that.
What should we look for regarding acute methamphetamine crisis and fentanyl?
So, and fentanyl?
Yes. Sorry.
Acute methamphetamine crisis and fentanyl.
Uh-huh. Yeah.
So methamphetamine crisis is typically characterized by a lot of psychomotor agitation and also can have some psychosis associated with it. So loss of touch with reality, doing sort of bizarre paranoid things. Those are signs that somebody may be in danger. And in some of those situations, they do need emergent help, right? Like they need to go to the emergency department, they need medications, they need to be able to be in a safe environment. When it comes to fentanyl, I would encourage you, if you are in a home or if you are regularly in contact with somebody who uses either methamphetamine or fentanyl, or really anybody who buys powdered drugs, then I would make sure that you have Narcan available and know how to use it. Because, like I said before, the drug supply is contaminated and they are in danger of overdose from fentanyl, which can be rapidly fatal.
There's a question about whether or not Barton's addiction treatment services are at risk given the recent DOJ grants being canceled, and just wanting to know what the status is.
Yeah, so a couple things about that. First, Barton has been extremely supportive of increasing addiction medicine treatment services. The Community Health Needs Assessment regularly reports that the top concerns for people in this community are substance use, mental health, and access to care. And it's on that foundation that we're building addiction medicine services. Federal grants have been supporting our Substance Use Navigator program, and those grants have been coming from SAMHSA. One of our most recent grants was in threat, and it because some of that SAMHSA money was withdrawn, what we did is we submitted our funding for a request for funding immediately on an accelerated timeline. And we're waiting to hear. We did get partial funding. A lot of our funding actually comes from opioid settlement funds, which are not caught up in the federal changes around funding requirements or regulations. And so we do have some sustainable grant funding that we're going to be using for the next few years coming from the county and also from the police department. And my goal is to use those funds to increase services. Just to come back again, just in case that all got lost, we are going to proceed with addiction medicine services with the support of our institution, and we will be able to provide addiction medicine care.
Great. This might be the last question, but I'll keep looking, making sure I didn't miss anything. And this kind of ties back into a question that was asked earlier. Just being that you're a local provider, do you think more can be done in Tahoe to raise awareness about substance use disorder, especially since it's so embedded in the culture? Any ideas of how local residents can help spread the word?
I have a lot of thoughts on that. I just did an event on Tuesday. We did a screening of a movie called Fentanyl High at the high school, and we had a panel discussion afterwards to talk about substance use and specifically about the dangers of fentanyl. I think there are a lot of really wonderful community organizations who are working on this and trying to increase awareness. And I think to some extent too, it is a cultural grassroots effort of people talking to other people about their concerns, helping to get people into treatment, normalizing treatment, understanding the stigma, and other factors like that. You know, it's kind of like a rising tide. And if we are all holding ourselves to a standard of saying treatment is okay, that's very helpful.
Wonderful. Well, this has by far been one of the most engaging Q&A sessions on a recent community webinar. So I really appreciate all the great questions and that you felt comfortable asking them. I'll just remind you, and I'll look in case anyone has any last minute questions you want to get in there, but I'll start wrapping it up by letting you know that this webinar was recorded tonight. It will be available on our YouTube channel and on our Facebook page. And there will be a short survey at the conclusion of tonight's webinar. We would love your feedback. How did we do tonight? And are there topics that you want to hear more of in the future? That helps to shape the schedule when we put that together. I'm just seeing, let's see. Yep, I'm just seeing a lot of great talk and appreciation for the topic tonight, Dr. McNamara. So I think I'm going to go ahead and we're concluding with 2 minutes to spare and hope everyone has a wonderful rest of their evening. Thank you so much.
Thank you, everybody. You can always email me if you have questions, and I'm in clinic about once a week, so I'm happy to see you if you need help.
Thank you.